بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الحمد لله والصلاة والسلام على سيدنا رسول الله. Thank you, Adil, for the introduction. I'm very happy and glad to be here with this esteemed group of scientists, I should say. So I was requested to present a case of ischemic mitral regurgitation. I don't have a case in the box, but we'll go through the case and then we'll probably ask the panelists to see what is the best way to treat this patient. I have no financial disclosure, but it's a team effort. I work with Dr. Grimley, who is an adult interventional structuralist. He's my partner, Dr. Anas Mirdad from imaging, Dr. Fernandez from anesthesia, and many nurses, techs, and radiographers helps during these cases. Our case is a 74 gentleman who is known to have a history of diabetes, long-standing dyslipidemia, hypertension, chronic renal kidney disease with a GFR of 43, has history of bronchial asthma, peripheral neuropathy as a complication of his diabetes. He's an active patient. His cardiac history was relevant for a previous CABG 2005. He ended up having LEMA to LAD, SVG, grafts to OM, and BDA. He has severe LV dysfunction, ejection fraction of 30 to 35% range, moderate mitral regurgitation, paroxysmal atrial fibrillation. The patient for the past 6 months prior to presentation had progressive shortness of breath, class 3, sometimes goes into class 4, requiring prolonged hospitalization. He denies any history of chest pain. His hemoglobin was okay. His LDL cholesterol was controlled. Hemoglobin A1C was fairly controlled, and his BNP was elevated more than almost 1,800. His ECG, as you can see, sinus rhythm, narrow, complex. His Holter showed paroxysmal atrial fibrillations. He doesn't have left bundle branch block. His echo shows severe mitral regurgitation, LV dysfunction, some abnormal septal motion, and moderate mitral regurgitation. His effective regurgitant orifice area is the range of 0.43 square centimeter with an RV volume of 80 mL and LV end-diastolic volume of 207 mL, putting this patient in the range of severe mitral regurgitation. His coronary angiography, the surgeon did an excellent job, but as we all know, in the patient with risk factors, they do have a progressive native coronary artery disease, severe left main and 3-vessel disease. His SVG grafts to the BDA was patent. His LEMA graft was patent, supplying diffusely diseased LAD. Transesophageal echo shows a favorable anatomy for a tricuspid mitral tear with the central jet. So now this patient is being discussed in the heart team meeting. The option is medical therapy, surgery, which could not be a favorable, does not carry a favorable outcome in this patient. He has a patent LEMA graft. His STS risk score is 27. Doesn't have significant calcification or MAC. Tendyne valve is not really available in our center. So we left with the mitral valve tear to consider for our patient. So prior to mitral valve tear, we have assessed this patient for presence of ischemia to see if we can revascularize this patient. Unfortunately, he has minimal ischemia in the inferior posterior wall with ischemia total of 5%. He doesn't have angina. And so subsequently, we jacked up this patient medical therapy, trying to focus on the left ventricle. He is in the best guideline-directed medical therapy with appropriate doses. He's not a candidate of resynchronization therapy, and he went for AICD as ejection fraction was in the range of 30-31%. So the guidelines, European and American guidelines, there are some slight discrepancies. The European put if mitral valve surgery, if appropriate, as a first line. Then if the patient is not candidate or high risk for the mitral valve surgery, then probably the TEER can be offered to those patients who are asymptomatic despite high doses of guideline-directed medical therapy. and the American guidelines put TEER as a Class 2A recommendation. Now, surgical intervention in patients with ischemic mitral regurgitation, we know from landmark studies in moderate mitral regurgitation, adding restrictive ring in trying to repair the mitral valve during CABG has not been shown to decrease the LV remodeling. There was no clinical advantage in adding mitral valve to CABG, but however, those patients who ended up with a restrictive ring had a lower prevalence of future severe moderate mitral regurgitation, but at the expense of higher SVT neurological events and a longer procedure stay. In patients with severe mitral regurgitation, this study looked into comparing repair versus replacement with chordal preservation. This shows no difference in LV remodeling, no clinical difference between MVR and repair placement at 12 months with durable mitral corrections with replacement. However, in 2 years, the patient who had the repair had significant recurrence of moderate or severe mitral regurgitation, significant higher rate of heart failure, significant higher rate of readmission for cardiovascular event. There was no survival benefits because these are underpowered study. They calculated around 6,000 patients to be randomized to find any meaningful survival benefit. So when choosing MTARE for patients, you really need to identify specific criteria for the anatomy of the mitral valve. Make sure that it's not really in the red lights, though some centers, high volume centers, they don't deny a patient just based on this criteria, but we know that some patients are not suitable to have this intervention. The landmark co-opt trial, there is the recent publication of the 5 years outcome. It seems that the 5 years outcome seems to be attenuated simply because the protocol have allowed for patient to cross over from the device for the medical therapy to device therapy, with 45% of patients cross to the device arm, and 46% at 5 years 2 years did not require intervention because there is improvement in their mitral regurgitation. However, we know those patients have significant reduction in rehospitalization, heart failure, and death. The recent study, there's a study published recently called the Matterhorn, which is a non-inferiority study comparing surgery versus mitral a clip. 40% of the patient had ischemic mitral regurgitation, 72% had mitral valve repair, and 28% had the replacement. There was a non-inferiority between this from the device study in regard to the composite endpoint of death, rehospitalization, stroke, or the need for assist devices. However, on the long-term, patient had higher bleeding and atrial fibrillation in the surgical arm. This study is again underpowered, around 208 patients. A recent study presented in the TCT and published recently, called the ReShape study, included more than 65% of patients with ischemic mitral regurgitation, with a median LV ejection fraction of 31, median LVADB 205, with a median effective regurgitated orifice area of 0.25, median RV volume 36. So this study looked into patients with moderate, less severe mitral regurgitation. So probably this is a co-opt-like patient, but less severe, and shows there is a composite endpoint was reduced in regard to rehospitalization, death. However, there was no mortality survival in this group of patients. So another concept one need to be aware of when dealing with those patients, you need to make sure that this patient would really benefit from the intervention and is not a MITRA FR candidate or patient. We always would like to hope for a patient to fall in the co-opt-like patient. Our patient fell in the co-opt-like patient. So the procedure was really straightforward procedure. Your transseptal has to be as high as possible and as posterior as possible. We used a Pascal device. It was a straightforward intervention. So this is the intra-procedural TEE showed significant reduction in the mitral regurgitation with acceptable mean gradient at the end of the procedure with improvement of the pulmonary vein flow. So 1 year follow-up of this patient, he feels well, happy about the procedure, class 1 New York Heart Association. He walks to a nearby mosque for 4 to 5 times a day with no limitation, no cardiovascular hospitalization in the past 1 year. However, he had cataract surgery, and his most recent BNB is around 200. So in conclusion, I don't have bullet headlines, but this is an excellent articles. So you need to tailor your therapy according to your patients. There are appropriate patients who are co-opt-like patients who derive the best benefits from this intervention. The device really does not treat the disease. You really need to focus on the left ventricle treatment with guideline-directed medical therapy, resynchronization therapy if indicated, and EICD if indicated. However, if patients do not really fall in the co-opt-like criteria, then probably there are alternative therapies that are really available, like the percutaneous valve. Some patients may fall on just medical therapy or palliative treatment, and the device itself has a specific echo criteria, and you need to tailor the therapy to the specific needs of the patient. So the final message: the device does not treat the disease. Focus on the left ventricular function, and if appropriate, after heart team meeting discussion, TEER can be done safely with an excellent result. Thank you.